Welcome, everybody, to Health Wonk Review on Air, number 4. I am David Harlow, otherwise known as Health Blog, and with me today is Joe Peduta, one of our Health Wonk Review worthies, and we're excited to welcome you all today and talk about the latest edition of Health Wonk Review, hosted by Tinker Reddy, and we had an interesting selection of posts as usual. For those of you who are not familiar with Health Wonk Review, I invite you to check out healthwonkreview.com for the archives and for links to future editions, past editions, even some blabs about Health Wonk Review. You'll find them all there, healthwonkreview.com. So, Joe, in looking over current edition, were there any particular posts that you'd like to kick off our discussion with?
Yeah, I think a couple sort of struck me. One, just briefly, was Tom Lynch's discussion of Oklahoma. Somehow Tom was able to tie together fracking and earthquakes in Oklahoma. I guess in Oklahoma they had 2 earthquakes per year a few years ago, and now they have 2 a day. So, of course, correlation is not causation, although there's a very strong correlation between fracking and pumping wastewater down and whatnot. And the point of Tom's post is that there's also some other tectonic changes going on in the healthcare delivery system in Oklahoma. Namely, nursing homes and acute care facilities alike are having some significant budgetary issues. So, shockingly, the worthies in Oklahoma have now decided that they will not adopt Medicaid. They will realign Medicaid to expand Medicaid so that now more Oklahomans will have access to care. So there, of course, is some caterwauling by folks who are opposed somehow to expanding Medicaid to cover more poverty-stricken folks, but nonetheless, there it is. With Oklahoma making a change, I think it's what we may well be seeing here is a number of states will say, gosh, it doesn't seem like the Antichrist is actually going to show up if we do expand Medicaid, and given the reductions in disproportionate share funding for hospitals, et cetera, might make some good financial sense for us to take advantage of that. So a little bit off the beaten path, as Tom is want to do, but interesting way to tie those things together. How about you, David? What
Sure. I mean, just to follow on there, I think it's an important issue, sort of the Medicaid expansion issue. We sort of had our fill of the discussion and the litigation around the ACA, looking at states wanting to pull back from a mandated expansion of Medicaid. Some folks had even resisted the Medicaid expansions in the ACA because of the quote-unquote woodwork effect. Once the expansion was advertised, folks who were not eligible for the expansion would come out of the woodwork and would be eligible for plain old traditional Medicaid at state expense without the additional federal compensation, a reimbursement at 100% for expansion services. And if I'm not mistaken, Hillary is now talking about extending the expansion and the 100% reimbursement from federal government for expansion coverage in Medicaid. Of course, if elected, one of the many plans and proposals that have been tossed out around there in the course of the campaign. But, certainly an interesting one. And I think that in particular is an issue that many of us think is worth pursuing, the Medicaid expansion from a public health perspective, from a prevention perspective, probably a worthwhile thing. I don't know how you prevent earthquakes, but I think we do know something about preventing the cascade effect of needs on the healthcare front, and prevention is certainly one of those. And enrollment in programs like Medicaid is a way in there.
So I actually posted, not to toot my own horn here, but posted on Clinton Health 2.0, right. And absolutely right. Hillary's looking to allow states who choose to expand Medicaid to get 3 years at 100%. I think that 100% was supposed to go away next year,
Mm-hmm.
90%, so it's not terribly much of a hit. And that's 100% on the expansion of Medicaid from 100% of the federal poverty level up to 138 ballpark, something like
Right.
that.
Mm-hmm.
So she's going to go for 3 years and then 90% after that. And I wouldn't be surprised if she is elected, if that does gain some traction.
Yeah, I think that's an attractive idea. So one of the other perpetual issues that we're faced with is the high cost of prescription medications. And there's a post in Health Affairs this week that was part of our collection. Is high prescription drug spending becoming our new normal? Offered by Lee Purvis and Crystal Kuntz. And the question here is, how do we deal with this? We do have the $1,000 a pill prescriptions that we've heard about. We've heard about the value of some of these prescriptions in terms of avoided costs. And we also hear about the opportunistic, or the accusations at least, of opportunistic behavior on the part of pharma companies in pricing and marketing prescription drugs. There are obviously various ways in which you can assess the value of a medication. I mentioned the $1,000 a pill drugs. I'm thinking of the Hep C and other things like that, situations where you can avoid a liver transplant for the cost of a 90-day supply of pills, where that may cost $90,000, but it avoids a liver transplant, which is obviously much more expensive and has a much greater impact on a patient. And there should be recognized that there is significant value to having that available, having that medication available. I think the blowback comes when people look at what is the value of a prescription. There are more and more high-dollar prescriptions being offered, and many of them are being offered on a chronic basis. So it's not a 90-day course of treatment, but it's a chronic care situation. And sometimes these costs are unsupportable. Something not brought up in the Health Affairs post, but I'll mention I saw in the general news over the past week, there's a case of a man arrested for murder of his wife. He, when questioned, said that he came to the point where it made sense in his mind to end her life because the cost of her chronic medications was unsupportable. And it's obviously a horrible thing, but I think it's just an edge case, an extreme example of the problem that we're facing with high costs of prescription medications. And, the question is, how do we deal with this? Can we set prices at some more reasonable rates? Does that fairly reimburse industry for development of drugs and so forth, the research process? And I think the critique in this post is around the perspective that's taken by some, which is we'll charge what the market will bear. And if we can get away with it, so to speak, then that's an appropriate price.
Yeah, I think a couple interesting things. Many points well made there, David. There was a post a while ago in an earlier pre-blog edition of Health Wonk Review that talked about quality of life years and the British mechanism that was set up to assess that NICE in the UK has employed for some time. I thought that the Health Affairs post was particularly intriguing for a couple of points. One was the new cholesterol drug, PCSK9 inhibitors, cost about $1,100 a month, $1,200 a month. And that's a chronic condition. It's going to go on and on and on. And that sort of comes on the heels of increasing evidence that some of the other cholesterol drugs seem to have had no material effect on actual deaths from cardiovascular conditions. So the question is, okay, so $14,000 per year, what is the cost of that going to be in quality of life years, and how are we as a society going to sustain that? What really struck me in this post was that if they're used on a chronic health basis, that it's going to cost $150 billion annually, which is ballpark 5% of U.S. total healthcare costs. That's just a stunning figure for one drug that treats a condition, hypercholesterolemia, that other drugs treated and didn't have any material impact on mortality. So how, when, who's going to pay for this, and how does that work? At the same time, we have to realize that for-profit companies' primary responsibility is to increasing shareholder wealth. And from an ethical perspective, there's a reasonable argument that can be made that they are obligated first to promote shareholder wealth and only secondarily to help cure people. So we have the healthcare system, this free market capitalistic healthcare system, and to paraphrase, I believe it was H.L. Mencken, you deserve the government you get, and you deserve to get it good and hard. You deserve to get the healthcare system you get, and you deserve to get it good and hard.
Right. I mean, we are living with a certain philosophy, with a certain perspective that we've, both inherited and built upon. But there's certainly opportunity to change, but only if we make some fundamental changes in our system, and unclear what kinds of changes we can, in fact, make without dismantling the entire thing. Right. And the sort of the quality adjusted life years, one of the issues there is what's our baseline thought about what is the value of a life year. And that is something that perhaps should change over time. Unclear whether it does or how it does in sort of the standard calculations, and always something that may be worth a second look or another look. There's no end of material on the dollars and cents front this week, as in every edition of the Health Wonk Review. There's another post from Roy Poses on the question of executive compensation, looking at CEO compensation across hospital systems and senior executive compensation as well. And what's interesting to me is that the most frequently repeated justification for these compensation decisions is, well, this is market compensation. And it seems to me that in a certain sense, in order to protect themselves from the perspective of looking at, are we improperly compensating a particular executive, boards, and in particular, well, not in particular, both nonprofit and for-profit boards will devolve to some standards and say, well, here's a survey of executives in similar size institutions in the past year, and we want to recruit and retain someone who's in the top quartile or whatever, top decile, and therefore we must pay between X and Y dollars. And that is a justifiable level of compensation. So obviously it's a self-perpetuating system, and I guess the question to put on the table is, and I'll put this to you, Joe, and to anyone else who's listening, if you want to call in or type in perspective, please do. Is there another way of attacking this? Are we bound to only look at what does the community pay? What are other institutions in the community, other comparable institutions paying? Is that the only way to decide what is an appropriate level of compensation?
Well, to my mind, the we pay what other people pay is the same logic that got us the usual and customary, the old HIAA database, which led to charge inflation, and we saw where that went. And right now, it's become ludicrous that these charges are insane. And I think saying, well, just because the kid down the street did it, Mom, that means I can do it, right? that's the same logic that these institutions are putting out, saying that we have to pay this because the people down the street will. Mm-hmm. Well, what happens is a lot of these, as Roy noted in his post, a lot of these are not-for-profit institutions. And it just strikes me that when you pay somebody a market rate, or your perception of a market rate, at the same time that the performance of the hospital, of the institution, either on a quality of care and or a profitability perspective, is less than adequate, then there's no reason for that executive to do the right thing to improve quality or to improve profitability, or certainly both. So it's essentially the hospital industry, with that sort of logic, is saying that we're entirely fine with paying people more for crappy results because that's what everybody else does. Well, I would posit that that's what's got us into the incredibly screwed up healthcare system we have today. And until and unless somebody says, look, we are not going to compensate you for losing money and delivering crappy care, we're going to be stuck with this. And, fortunately, as Roy points out, there are a few institutions that seem to have a rather more intelligent approach to this, and one hopes that their focus on this is going to be rewarded. One more comment on Roy. He has been participating on Health Wonk Review for over a decade, and to his credit, he knows more about the seamy, dirty underbelly of the healthcare world pretty much any and everybody else. So just kudos to Roy for always sticking that mess out there in front of us, because that's where it needs to be.
Right, absolutely. So one solution, or one kind of solution to the problem here, would be to have compensation based on quality metrics and measures of some sort or another. And that leads to another post in this week's collection, which is Brad Flansbaum's post on the Hospital Leader, talking about or looking at quality measures. And his approach in his post this week is to simply clip the summaries from a number of articles, the conclusions, or the conclusions from a number of articles looking at quality measures. And the problem with our quality measures, aside from the incredible proliferation of measures that we're using, we have thousands at this point of measures, and one wonders whether those are going to be useful in such numbers. I've always said that I'd love to have like half a dozen meta measures that we could use to really divine quality from. But Brad's collection of articles shows that even using the measures that have been vetted and are generally accepted as being reasonable approaches to measuring quality, we get unusable results. The variation is not easily explained. The predictive value seems to be low, to quote one set of conclusions from an article. The other catchphrases here are, different methods of commonly used methods for calculating a certain metric produces substantially different results. That's not good. That's not helpful. Are higher measures under certain standards actually related to higher quality outcomes? Again, unclear. So the finally, limited validity for certain measures when measured against reference standards, and all of these standards that are questioned are being used in pay-for-performance systems. So we have this approach that we're going to take towards quantitative analysis in healthcare. And if we follow the numbers, we're going to know what's good and what's bad, and we're going to reward the good and punish the bad. And this is just one snapshot of the landscape telling us that perhaps we don't really know what we're doing.
Yeah. So, in defense of the healthcare system and the evolution going on in the healthcare system, up until very recently, nobody gave a rat's rear end about quality in healthcare. And there's lots of studies published that showed even when you did produce, Leapfrog or whomever produced reports showing hospital quality, nobody paid attention to them, the consumers didn't care, et cetera. Well, Medicare cares now, no pun intended, and they are promulgating and sort of forcing hospitals, healthcare systems, and whatnot to look into and to report on various quality measures. And that just getting the healthcare systems and whatnot reporting, and hospitals reporting, physicians reporting, is a major step in the right direction. But in fairness, I think we're really in the infancy of this whole process. It is akin to where manufacturing was a few decades ago, where a lot of the manufacturers really didn't understand what quality was until Six Sigma came in, until we started looking at lean manufacturing and Japanese processes, et cetera. And then manufacturing went through a very wrenching, very dramatic, and ultimately very, I think, successful change, in that you look at the quality of automobiles produced in this country right now, it is so much better than cars used to be. I'm an old car aficionado. I had a 1971 Plymouth GTX Hemi convertible, which was a wickedly fun car. What a piece of crap. So now I have a German engineered sports car. It is so much better, and it's reliable, and you turn it on, you can actually drive it. And I think the healthcare system is going to get to the German sports car, or even the American Ford Escort, or what have you. It's just going to take a long time, and it's going to be a wrenching process, and there's going to be a lot of pain and difficulty as we go through this. So all those measures are essentially people trying to figure out what works and what doesn't. How do we help people buy healthcare? How do we help payers assess whether it makes sense? How do we help improve healthcare? Just one more point on that. Our daughter is an emergency room nurse, and one of the quality measures that Medicare uses is patient satisfaction. Well, she was an ER nurse in an inner city in Connecticut, and the amount of drug-seeking behavior there was remarkable. And of course, when they did not give out opioids, their quality of care went down and the ratings went down. And there was a move by the hospital administrator at the hospital, which shall remain nameless for obvious reasons, to say, look, we need to increase our quality of care. You need to do what you need to do to make that happen. She left and said, this is crazy. We can't, this is not a way to deliver care. And I think as CMS gets more intelligent about this, we will evolve in that direction. So I think we just have to recognize that we're in the early stages of the whole quality look, and we're going to get a lot better, a lot smarter at it. I think 5-10 years from now, we will look back on this and say, wow, that was the infancy, and now we're so much better. So Brad's absolutely right. It is a cluster mess right now. However, I think that's a necessary process you go through to get to where you need to be.
Okay. Any fearless predictions of when we get there?
Later rather than sooner. How's that?
Yeah, I just feel it's been a long road already, and I think a lot of us want to get there already. Particularly given the fact that so many of these quality measures have been vetted and tested and looked at through various pilot programs for CMS and otherwise. And they, to a certain extent, they're motivating certain kinds of good behavior. To a certain extent, they motivate a very narrow range of good behavior. And sometimes my concern is that other stuff just sort of falls off the table if we focus on, the 10 measures in front of us at any particular time. So that's an ongoing concern, I think.
Yeah, that's actually a really good point. I did a brief project at the Geisinger system in central Pennsylvania a number of years ago. And back then I knew so much more than I do now. And I was pontificating on quality of care measures and how they needed to embrace those. And a doctor very diplomatically pulled me aside and says, well, let me tell you about quality of care measures. And he's a gerontologist, and he would have patients who came in with 4, 5, 10 chronic issues, conditions, et cetera. And he could not do everything he needed to do to test their eyes for glaucoma and look at their blood pressure and check for blood sugar and do everything else, just because he would be spending all of his days with 1 or 2 patients. So he said, I have to triage in my mind what's most important for these patients and operate on that basis. And I'm getting dinged on quality because I'm not doing everything.
Mm-hmm.
I have to respect what the patient is about, et cetera. So we are asking, I think, not enough in some circumstances and too much in others.
Yep, fair enough. So what's next on our docket here? Another post you'd like to discuss in our remaining time?
An interesting post by David Williams, which was about part of his practice involves dealing with private equity firms who are investing in healthcare entrants in this business who have $5 million of earnings and whatnot. And David, clearly smart guy, does a lot of work with these, but I think his point was that there's a lot of investing that goes on where people don't really understand what that particular aspect of the healthcare delivery system is or how this company is going to interact with that. They have in my view, either a not deep enough view into that particular slice of the business, or they have, or they don't understand, or they have a deep view into that slice of business, but don't understand how it interacts with other slices of the business. And that, I think, is where these businesses fail when they fail. They can't grow beyond a certain niche. So David's point is that these businesses all have opportunity, but you have to look at them in the perspective of how well do they serve that particular area, and equally importantly, how well do they mesh with the rest of the healthcare delivery world, and where are they going to be going forward? So I think we have a tendency to go after the bright, shiny object and not understand that that bright, shiny object does not exist in a universe by itself, and it's got to interact with other things. So I think that's a very valid point made by David.
Yeah, excellent point. And the issue in general of trying to see inside the world of a startup and understand the projections, understand the business plan, understand how it all works. We've seen a couple of dramatic flameouts recently, which have led us all to question, what were those people thinking? But the lesson extends to not only the realm of the unicorn, of the $1 billion plus valued startup, but also the much smaller startup where people are looking at investing, looking at planning for the future, trying to figure out how is this company going to interact with the rest of the system. Because that's really the important takeaway, as you said, Joe. It's part of a whole system. It doesn't operate on its own. It doesn't live or die on its own. It's not like a standalone business in another sector of the economy. There's so many interconnections and interdependencies that exist that it's important to have a pretty holistic view of the system.
So coming up, I think as we get more into election season, speaking of cluster messes, it's going to be interesting to see how Health Wonk Review sort of evolves to, or not evolves to, but focuses a little bit more deeply on some of the political issues. And I just have a question for you. Do you have any insight into, do you have any understanding of what the presumptive Republican nominee's healthcare platform is? Because you're a really smart guy and you're very insightful on these things. So I've been trying to figure that out, and I've been at a loss, David. So I'm going to put you on the...
Well, thank you, Joe. I've actually had a conversation with a reporter yesterday about the health plans of the three front runners, and hopefully I'll be able to share a link to some discussion about that in the near future. But I think the brief takeaway is that, as in many other aspects of his platform, he's playing to the crowd, and it's a mishmash. There are actually a couple of good ideas thrown in there, but a lot of it is sort of the mishmash of the playing to the crowd. As I said, the notion that no illegal alien should receive any health care in any healthcare facility in the United States of America is a little shocking, to me at least. Some of the notions around expansion of tax deductibility for health insurance, I think makes a lot of sense. Folks who get health insurance through an employer do so in a tax advantaged way. If someone is purchasing health insurance not through an employer, and in a Trump world, the ACA would be repealed and we wouldn't have exchanges as they exist today. Folks who are purchasing insurance ought to have a similar tax benefit. I don't think that's an objectionable proposal. But again, it's wrapped together with things like no health care for legal aliens and a bunch of other things that I think are objectionable.
Well, look forward to reading more and about that on your blog going forward, and I'm sure it'll make for a spirited political conversation. Hopefully, we can get some folks from all sides of the. It's not an aisle anymore. I think it's sort of a central barber pole or something that we're all sort of about to get some other insights from some other folks on this.
Right. Great. Well, this has been good. Our half hour has flown by. Joe, thank you again for engaging with me in this conversation over time. I'll be hosting the next Health Wonk review on my blog and later next week, and we'll return to this discussion the week after that. Thank you all for listening. We look forward to getting your calls and letters and any other kind of communication you'd like to share with us, and we will see you next time here on Health Wonk Review on Air.
Thanks, David. Much appreciated.
Bye, Joe. See you next time.
See you next time.